Hi, welcome to Chapter 7. I want to start with a scene. It's 3 a.m., your phone lights up, and it's Jasmine, 32 weeks pregnant. The text says, "Is it normal to have a headache at 3 a.m.? My face looks kind of swollen, but maybe I'm just tired." Now, everything you've learned about normal pregnancy, the matrescence, the relaxin, the coffee cup explanation, none of that really tells you what to do right now. What tells you what to do right now is in this chapter. This is the chapter where things go wrong. Not every pregnancy, not even most pregnancies, but complications happen, and they happen to real families, and they happen at real rate. Preeclampsia affects 5 to 8% of pregnancies. Gestational diabetes affects 6 to 9%. Group B strep colonizes about 1/4 of healthy pregnant women. Decreased fetal movement is one of the most common calls that a doula will receive. And these are not rare edge cases. They are the ordinary landscape of prenatal work. Something needs to be said directly before we go any further. This chapter is heavy. You will finish it knowing that pregnancy can become dangerous quickly and that the medical system does not always catch it in time, especially for Black women in Louisiana. That is a hard thing to hold. It's also necessary to hold because the doulas who serve these families with full awareness of the stakes are the ones who are going to show up differently. They're going to notice things that others dismiss, and they're going to stay when it would have been easier to defer. They make the call that turns out to save a life. And that's not fear, that is preparation. And preparation is what this chapter is for. Your scope of practice does not change when things get complicated. You still do not diagnose. You still do not prescribe. You still do not override medical advice. Those lines do not move because the situation is serious. What changes is the urgency. You are an educated witness, not a bystander, not a clinician, an educated witness who knows what to look for, who can describe what she observes accurately, and who understands when a symptom pattern requires action rather than reassurance, and who knows how to persistently help even when the medical system is not responding the way it should. If you remember nothing else from this chapter, remember this section on preeclampsia. So let's start with the name, because the name is a teaching tool in itself. Preeclampsia does not mean before birth, it means pre-seizure. Eclampsia is a pregnancy-related seizure. Preeclampsia is the condition that can lead to it. And that distinction matters for 2 reasons. First, it tells you that this condition is not slow or mild, it's on a path towards a medical emergency. Second, it tells you that the danger does not end at delivery. Eclampsia can occur up to 6 weeks after birth. Preeclampsia can develop or worsen in the postpartum period. Every postpartum visit you make is also a preeclampsia screening visit. Here's what is actually happening in the body. The blood vessels that should dilate during pregnancy are going to constrict instead. Blood pressure will rise, and blood flow to the kidneys, the liver, the brain, and the placenta are going to drop. The body is going to show signs of organ stress, and this is why preeclampsia is not just defined by high blood pressure, but by evidence that the organs are being affected, like protein in the urine, or elevated liver enzymes, or low platelets. Now the warning sign cluster. This is what to listen for in every call, every visit, every text message. Severe persistent headache, not a regular pregnancy headache that improves with rest or Tylenol, but a headache that does not go away. When a client describes the worst headache of her life, that phrase is clinically significant. Vision changes, blurry vision, spots, flashing, dark areas, temporary vision loss, double vision, light sensitivity, any of those. Upper abdominal or right rib pain, that sharp stabbing or constant pressure right under the ribs, that's not heartburn. If it doesn't improve with acids or position changes, that is the liver under stress. If they have sudden swelling in the face or in the hands, not the normal ankle swelling at the end of the long day, but facial puffiness, especially right around the eyes, or if they have rings that suddenly do not fit on their hands or swelling that comes overnight. And here is the part that clients almost always underestimate is the combination of any of those 2 signs is the signal. So Jasmine had a headache and facial swelling. Neither one alone is necessary to require a call at 3 a.m. They require a call immediately. One more thing about preeclampsia is that you cannot feel high blood pressure. A woman could have dangerously elevated blood pressure and feel essentially normal until it's already reached a level that's beginning to cause damage. This is why those prenatal appointments matter even when she feels fine. The absence of symptoms is not necessarily a reassurance. By the time she feels symptoms, the condition may already be significant. Now, the part that everyone forgets is that preeclampsia does not end at delivery. The highest risk for a woman who has preeclampsia postpartum is going to be 24 to 72 hours after birth. Serious postpartum hypertension can develop up to 6 weeks after delivery, and women who were fine during pregnancy can develop preeclampsia after they go home from the hospital. Many women who die from preeclampsia die in the postpartum period, and many of them could have been seen by a doula between discharge and death. So your postpartum visits are not just support, they are surveillance. At every contact in the first 6 weeks, ask about headaches, ask about vision changes or upper abdominal pain or any new swelling. If she reports any of those symptoms in the postpartum period, help her to contact her provider or get to the emergency room the same day. And this belongs in this section, not in a separate chapter, because it is clinically inseparable from what we just covered. In Louisiana, Black women are 60% more likely to develop preeclampsia than a white woman. And the disparity is not just in rate, it is in outcomes. Black women with preeclampsia experience higher rates of progression to eclampsia, higher rates of stroke, higher maternal mortality. The disparity persists across every income and education level. A Black woman with a college degree faces higher preeclampsia-related mortality than a white woman who did not complete high school. The mechanism is not biology. It is the documented pattern of a Black woman's symptoms being minimized in the clinical setting, and the psychology of weathering that accumulates from living in a society that has historically treated Black lives as expendable. What this means concretely for your practice is that when a Black client reports a persistent headache, your threshold for encouraging a provider call should be standard for every client. Not because you are treating anyone differently on race, because evidence tells you that she is statistically higher risk of having that headache dismissed by a system that has dismissed Black women before. So your presence as a continuous, attentive doula is itself evidence-based harm reduction for women. It's not incidental to this work. It is the work. Now let's talk about gestational diabetes. When a client calls to tell you that they failed their glucose tolerance test, the first thing she needs is not going to be clinical information. It's this. She needs to know that it's not her fault, that she hasn't done anything wrong. Gestational diabetes has an image problem. It sounds like it's something caused by too much sugar or by eating wrong or not being careful enough. And none of that is true. It's caused by placental hormones that create insulin resistance during pregnancy. The pancreas simply cannot produce enough extra insulin to overcome it. And a woman with a perfect diet can develop it. A woman who ate poorly may not. In about 90% of cases, it does resolve completely by delivery once the placenta is gone. What it does require is blood sugar management during pregnancy to protect both the mother and the baby. The chapter is going to walk through the testing experience, the management, the conversations to have, and the lifetime risk of type 2 diabetes that some clients might face. Now let's talk about group B strep. This one is mostly about education because about 36 to 37 week mark, your clients are going to be tested. And about a quarter of healthy women are going to test positive. Positive just means that the bacteria has colonized. It doesn't mean that you're necessarily infected, and it doesn't mean that it's dangerous to her. What it does mean is that there is enough of that bacteria in the vagina that when the baby is delivered, it will come into contact with it. So we're going to give her IV antibiotics, typically penicillin, to prevent that transmission from mother to baby. The antibiotics reduce the risk of transmission by approximately 80%. So the protocol is to start the antibiotics at least 4 hours before delivery when possible. Your role is to help her understand what is happening, to help her communicate her preferences within that framework, and to support informed decisions in whatever direction she chooses. Kick counts. Decreased fetal movement is one of the most common reasons a client will call you and one of the most important things to take seriously. Teach every client, starting around 28 weeks, to do daily kick count. Pick a time when the baby is usually active. Lie down on your left side and count the movements. The goal is 10 distinct body movements within 2 hours, though most babies are going to hit that mark in under 30 minutes. If she hasn't felt 10 movements in 10 hours, she's had a cold, sweet drink, she's lied on her side for about 30 minutes, and she counts again and doesn't feel movement, she needs to call her provider immediately. And that's not a suggestion, that is the protocol. And here is the rule that overrides everything else. If your client tells you the baby is moving less than usual, take it seriously. Not, oh, you're probably just busy and not paying attention. Not, baby, slow down at the end. The current research is clear. A consistent change in the movement pattern is one of the most reliable warning signs we have, and the cost of being cautious is low, whereas the cost of dismissing it can be catastrophic. The call now versus call during business hours framework is in this chapter, so make sure you memorize it. Then there are warning signs like heavy vaginal bleeding, severe abdominal pain, leaking fluid, decreased fetal movement. All of that does not resolve with a kit count protocol. The signs of preterm labor, preeclampsia warning cluster, and the signs of infection, those are the go to the labor and delivery unit now warnings. Mild swelling, occasional headaches that respond to rest, normal pregnancy comforts, routine questions, those are the things that can wait for the next business day. And there is one more skill in this chapter that does not get enough airtime: what to do when a client reports a symptom and is dismissed. Step 1, encourage her to call back and describe the symptom cluster more specifically. Not just, I have a headache, but I've had a headache for 6 hours, it's not responding to Tylenol, and my hands look swollen. Specificity changes how the triage nurse is going to hear the call. Step 2, if she still feels dismissed and the symptom picture concerns you, suggest she go to the labor and delivery unit for evaluation without an appointment. She does not need permission to present. She can walk in and say, I'm 34 weeks pregnant and I've had a severe headache for 8 hours with facial swelling and I need to be evaluated. Any labor and delivery unit is required to assess her. Step 3, if she's in the hospital and feels she's not being heard, she or her support person can ask to speak with a patient advocate or the charge nurse. And that is not dramatic. That is using the system as it was designed. And document everything. Write down what she reported, when she reported it, what action was taken or recommended, and what the outcome was. Your notes may become important later in ways you cannot anticipate. One last piece, because we work in a state where the numbers shape the stakes. Louisiana has one of the highest maternal mortality rates in the United States, and disparity by race is profound. The state's own data tells us that the families we serve, particularly minority and Black families, are at a higher risk than they would be in almost any other industrialized country. The vigilance this chapter is asking from you is not abstract. It's the answer to a specific question. Why do we need doulas? Because the system on its own has not been catching these things in time. So read chapter 7 carefully. Read it twice. Know the preeclampsia warning signs and know them cold. Memorize what happens in the postpartum window. Internalize that threshold for your minority clients. Practice teaching kit counts out loud so that the words feel familiar with you before you need them. And put the call now versus call during office hours framework somewhere you can see it. On your phone, on your prenatal visit checklist, in your kit. And before you move on, ask yourself one final question in this chapter. Has there ever been a moment in your own life when someone took a small concern of yours seriously and it turned out to really matter? Or worse, was there a moment when no one did? Remember that feeling. Then become the person who does not let that happen to your clients. I will see you in chapter 8.